All right, so we will plan to get started. I want to welcome everybody to the Fall Population Health Collaborative meeting. This is co-hosted by the North Carolina Medical Society and the North Carolina Healthcare Association. I'm Martha Chestnut. I practice internal medicine at Boyce Willis Clinic in Rocky Mount, North Carolina. So we're up in the northeastern part of the state in Edgecombe and Nash counties. Today we're going to talk about telemedicine in the age of COVID. We've got a lineup of great speakers who will give an overview of what's happening nationally as well as locally in North Carolina and see the trends that have developed, as well as start to plan ahead for the future in the coming months and years as we transition, hopefully with telehealth being a mainstay in the practice of medicine. A few housekeeping notes for security. The webinar is set up with a password protection. However, we have heard of Zoom hacking. So if we happen to see or hear anything inappropriate, we will do our best to remove that person from the meeting. If further troubles persist, we then will immediately end the webinar and follow up with you via email. This webinar is being recorded, and a copy of all the materials will be available on the North Carolina Medical Society site. And we'll actually send out email with additional information as well. For chatting and making comments, there are two places that you can do this. Please use the chat function for casual communications amongst yourselves. It will be monitored. And then please use the Q&A function for specific questions you have for the panelists and about the presentations. We'll monitor that, and we want this to be as interactive as possible given the virtual format, as I know that we relied on this being very interactive in the past, so please virtually interact with us as much as possible. I do want to give a little bit of background for how we have utilized telehealth at Boyce Willis Clinic. As I mentioned, we are in about an hour east of Raleigh in Nash and Edgecombe counties where we practice medicine. Boyce Willis is a multi-specialty clinic with about 70 providers. And so I thought it would be helpful to give a perspective for what we've seen in the past with our telehealth visits and what looks like the lineup in the future. So I'm going to attempt to share my screen. So can you all see that now? Anne, are you able to see my screen?
Yes.
Okay, perfect. And so if we go to the second slide here, what you can see is just by department. The light blue are arrived televisit appointments that occurred between April and August. And then the dark blue are the percentage of appointments that are scheduled upcoming from September until the end. So I think it's really interesting. You can see we had a slow uptake of telehealth in certain departments. And then we had on the right-hand side of the graph, you can see we had an especially increased amount of telehealth visits in some unexpected areas. If you look at rheumatology and endocrinology, we were very surprised with how successful they were with telehealth looking back in the past, the last few months, and then looking forward with the transition in that. So I think relevant to today's conversation, I think it's very interesting to look at endocrinology with them being so successful in engaging patients to do telehealth, and that's always, from a population health standpoint, a difficult population for us to take care of, and we have a lot of quality gaps and costs that are associated with those patients. So this may be a way going forward that we can continue to interact with our endocrinology patients, particularly considering those to be diabetic patients. So I think that's an interesting trend for us to follow. And then one unanticipated one certainly has been rheumatology. I can see where he has, as a department of one, has really transitioned a lot of his patients to becoming telehealth for their follow-up appointments. So I think that'll be another interesting trend for us to follow as an organization. And we weren't too surprised with how internal medicine and family medicine did. Certainly it appears that our family medicine providers have engaged in the patients in those departments to continue on, because you can see we have 20% of our upcoming appointments are through telehealth and family practice, and 10% in internal medicine. So I thought this might give just an interesting perspective of what we've seen and what we anticipate seeing as we set the stage for our speakers today about telehealth. So I'm going to stop sharing my screen and introduce you to Ann Dolan and Daniel Bradford of IQVIA. And they will present on national and North Carolina telemedicine trends that have occurred during COVID. Ann Dolan is presently a practice leader, population health management, healthcare technology services. Here she serves as a member of the healthcare leadership team, as well as spearheads all system population health and telehealth initiatives. So we are delighted to have Ann presenting today. Dan, who is her co-presenter, is a Senior Associate Director, Data Services and Advanced Analytics. He has 10 years in Advanced Analytics, leading retrospective claim studies and predictive analytics. So we will go forward with their presentation, and after this presentation, we'll have a brief break for questions regarding this particular presentation. So Ann, I'll turn it over to you and Dan.
Thank you, Dr. Chestnut. Can everybody see the screen okay?
Yes, looks good.
Okay, wonderful. We thank you for the opportunity to serve the North Carolina Healthcare Association. We support your mission, your vision, and your values, and we also welcome the opportunity to support your members today in achieving population health goals, which is basically a triple aim approach of improving quality and outcomes while increasing and enhancing patient engagement and patient experience while we help reduce costs of care. Today, traditionally, healthcare has been provided in the physician office, hospital or outpatient clinics, and patient care has been primarily a face-to-face visit. But technology is now changing how and where care is being delivered, and many patients are now expecting to interact with providers online. So for purposes of our telewebinar today, we're going to be using definitions as clarified by the American Academy of Family Physicians. So telemedicine is defined as the practice of medicine using technology to deliver care at a distance, where telehealth refers more broadly to the electronic and telecommunication tools and services that support that care. So telemedicine can be referred specifically to remote clinical services, while telehealth refers to non-clinical services. Now let's evaluate the impact of COVID-19 as it relates to telehealth. IQVIA takes a weekly snapshot of the healthcare landscape. We publish bi-weekly with a mix of different contents, as you can see on this slide, from office visits to unemployment needs. Overall, office visits are up, face-to-face increasing. There's been a drop in electives and procedures and actually a decrease in lab. Unemployment is trending down, and we will review unemployment in greater detail in our upcoming slides as we focus on population health in relation to telehealth and social determinants of health. Some specialties like oncology or dermatology, they are coming back above baselines. Like here in oncology, we're seeing diagnoses. Telehealth is making its presence, augmenting office visits as a meaningful option to access to care. This captured 1.7% of the office visits just last week, and it's showing that it's not as prevalent compared to the early stages of pandemic. We've been aware of different types of trends and looked at different measures that really don't hit the news feeds. And early on, CMS released funding during the shutdown, specifically relating to rural care delivery. There really exists a public health challenge. There are vulnerable populations, immune compromised, that really need to begin to show up. And patients now need to show up for returning to the office visits, and they're looking at visits from a different type of lens, so to speak, and assessing their risks. There is an ongoing investment being made to focus on bringing care directly to where the patients are. And as you can see, CMS is planning to award agreements and plans to accelerate that, selecting different ACOs to actually participate. We see that telehealth has grown dramatically, and it's now much wider use, adding over 135 services. It continues to be reimbursed than from previous pandemic era. This does exist in some emerging pressures though, now whether or not to continue the parity for telehealth. In August, the CMS actually had an executive order that signed an expansion of telehealth beyond the pandemic with the focus on improving the both broadband infrastructure to support technology and emergency room visits. There now exists an opportunity to integrate social determinants of health here to evaluate what type of visits are needed, whether it's a person or virtual. That could be either in needed or warranted. So basically, in summary, telehealth is here for the foreseeable future. What we see in this data is very interesting, that telehealth has found a rightful place in patient care. There is a dramatic shift, as you can see on the left bars, and the blue bars, that telehealth has demanded a presence in the pandemic era. And it has remained below baseline levels. Over to the right, we can see both office visits, institutional, and telehealth, where telehealth has actually increased over the past 23 weeks. Telehealth absorbed 1/3 of the office visits during the rise of the pandemic, and it actually grew tenfold from the whole pre-pandemic use. Prior to the pandemic, telehealth was basically and exclusively used for behavioral health and mental health issues and conditions. This slide is interesting because it actually shows rapidly behavioral health and ADHD accelerating up to 60%, which we were inferring maybe reflected the impact of the virus on the overall population health. This one area has a very significant utilization and adoption in telehealth. The specialties had less shift to telehealth. But beyond this slide, there are other specialties like dermatology, oncology, and even orthopedics that are now adopting telehealth. Virtual care will continue to augment the delivery of in-person care. And at least at this point in the pandemic, there is now a trending down in telehealth as we continue to move forward and open. As we look forward to growing in the hospital access, right? We've given the growing capacity issues. We know about system testing limitations. The recovery rate for many electives remains pretty stable. So when we look at the country, we're very aware of the hotspots and the pandemics. And we are seeing a delay in some of these electives just below where they were, but some are coming back. And the highest case growth are still open for business and healthcare. So as you see with North Carolina here in the light blue, we remain up, North Carolina is in the top 25%. We're going to take a little shift because with the pandemic, there's been a focus with unemployment. And this shift gears to provide insights on unemployment, which really directly affects the socioeconomic status of patient care. COVID-19 has had a historic shift in unemployment. The highest rate in the recession back in 1982 was 670,000 unemployed. Early March, we had 1 million, reaching 7 million in late March. What's affected in unemployment is the payer shift relating to insurance. So not many had insurance or now need to move into another payer group. And this payer shift has significantly affected the healthcare managing our patients. So as we look, we are in a very interesting times. Many of the jobs lost were low paying. Areas that were impacted, you can see in the red, personal care services, community and social services, transportation. I personally went without a haircut for over 4 months. So these areas, patients have had no option but to move into a Medicaid channel. And to understand the Medicaid payer channel, we wanted to understand what happens when the market becomes in shock and how it manifests itself in Medicaid enrollment. This chart actually looks back to the effects of unemployment back to like the recession in 1998 and how unemployment spiked and then changes into Medicaid. The pattern actually shows an 18-month to 2-year lag time to peak Medicaid. So as we see over here in the ACA expansion in the light area for the past decade, enrollment in Medicaid has been very significant. When we index cases of unemployment relative to cases per 100,000, and then we added a third dimension looking at the ACA expansion. So we're now beginning to see areas of the country that actually have a higher likelihood of unemployment, battling COVID at the same time, which then becomes relative to their ability to access Medicaid. Dynamics begin to emerge and now tell a very different story. Basically, parts of the country are much more likely to have patients move into Medicaid. So we see here with North Carolina and South Carolina and Georgia, your neighboring states. And this is what we're actually seeing in reality. So when we begin to track where patients are changing coverage from Q1 2020, then fast forward to March, we are now seeing the payer channels are actually changing as well. 7% of patients that had commercial coverage are now beginning to change payer coverage. We're seeing increase in cash and cash discount cards, the SNAP program, as you can evidence by 65.6, the blue and white dotted lines here in these graphs to the left. We see a difference in expansion versus non-expansion states and how the patients are actually using their health care. Expansion states are threefold increased. It's easier for expansion states to actually enroll in Medicaid. So as you see to the right with North Carolina, we're averaging at about 6.5% coverage switch. Also, what is really important too is measuring how many patients are actually taking themselves out of the market and not getting access to care. So we began to look at inactivity. And many patients had elected to stay on the sidelines during the COVID pandemic that would normally have been very active. 20% of overall employee-sponsored coverages were basically inactive. And that results in about, I think, like 1 out of 4 in 2020. So across the country, heavier predominance and heavy in the southwest area here. We're not really quite sure. We don't know if that's reopening or closings. We're continuing to take a trend over time with that. If we look at North Carolina here in the light blue, it represents probably about 23% rate. And this is also very interesting because as we look towards discount card programs, basically discount cards increasing their cards that are used for paying cash for pharmacy. It's an ability for us to understand and indicate how members are actually moving into Medicaid enrollment. So remember when we talked about the lag, the 18-month lag, we are now beginning, this lag may indicate that it is beginning to play out right now. So let's take a look at North Carolina's scorecard. When we drill into your state level and understand your local markets, on the left we have the timeline from pre-pandemic, from the start of pandemic down. North Carolina right now is in a pause status. You have bars are closed, alcohol is after 11. The average case count is trending down. Elective surgeries are down compared to the national. And interesting about telehealth that can be found in the lower right-hand corner here. Telehealth utilization is at 13%. And that's better than in other areas, especially with your neighboring states. Georgia's at 11%, South Carolina is at 9%, and the VA, Virginia, is at about 15%. And overall, your unemployment is a little bit better, but slightly a little worse than average national spending. So at this time, I'd like to introduce Dan to now expand on social determinants of health that directly affect and relate to unemployment, health, housing, and socioeconomic measures. Dan?
Thank you, Anne. Yeah, this is Dan Bradford. I'm in the Advanced Analytics group at IQVIA. And recently we engaged with Anne to run a proof of concept looking at the impact of social determinants of health on 30-day readmission rate for heart failure patients. We used this example, seemed like a good goal to start with, but we know we can expand this to other areas. So I'll start a little bit going through the methodology of what we did and then get into some of the initial results, especially focusing on how they impact North Carolina. So our approach was to identify patients in IQVIA claims data sources that had an admission for heart failure during 2019. And then we looked forward for those patients 30 days and measured which patients had a readmission. And that was sort of the outcome that we wanted to be able to predict. We also used IQVIA claims to look back for those patients and analyze prior treatments, comorbidities, hospitalizations, so that we could control for medical factors in our model. We also went out and collected from public sources, such as CDC and census, data at the county level describing various social determinants of health features about the counties. And so we really focused on the county level for this proof of concept. We were measuring readmission rate at the county level and trying to predict that rate based on what we saw in terms of demographics in that county and also what we see for the patients in our data, what medical history they have. So for now, the focus was really on this modeling and measurement, trying to determine the impact of social determinants of health. We'd like to kind of, as next steps, try to apply this so we can truly understand the impact for payers, providers, and patients. So this is sort of describing again the approach. Just to highlight here, we gathered more data than we needed. So we gathered about 900 variables at the county level from public sources. So our approach was to use some kind of feature selection techniques to identify the public data that were most useful in predicting patient readmission rate. And then using those most important variables and trying to map them to 5 key domains of social determinants of health. And these are identified by the Healthy People 2020 initiative. So we have economic stability, health, education, social, and neighborhood. And so what we did is try to map, as I said, the most important public SDOH features to one of these 5 key domains. And then for each domain, we come up with a composite score to measure for each county where they stand in terms of each of these domains. And that's what we use in our model when we try to measure the impact of each of those domains. So now I'll get into some of the results. So again, the model is attempting to predict readmission rate based on the 5 social determinants of health domains, as well as controlling for medical history, things like number of relevant comorbidities and treatments, and number of prior hospitalizations, as well as simple demographics like age group, gender, things like that. And so what we found is interesting. So the results, or the direction of the results, seem to be in line with our expectations. So this slide is showing the average impact on the readmission rate. For example, for economic stability, when we look at poverty level, we saw that a higher rate of poverty in a county on average resulted in an increase in the readmission rate of about 0.23%, relative to what we would expect if we only looked at medical history. Similarly, for education, the education domain, we really focused on levels of professional employment. And we found that counties with higher levels of professional employment saw lower readmission rates, and the overall impact on average was about 0.12%. Now we can start to look at some examples of counties. We pulled some example counties in North Carolina, and we'll also get to see these as we go into the tool in a little bit more detail. But just as examples of what we can look at, we highlighted 3 counties. So New Hanover County, Pitt, and Brunswick County. We see that in New Hanover County, the readmission rate is right around the national average. So we saw nationally the average was around 12-13%. And we can see that after controlling for medical and other drivers, the impact of social determinants of health, the combined impact is less than 0.1%. So not really an issue in New Hanover County. While in Pitt County, we see a relatively higher readmission rate, especially compared to nationally. And we see, based on our model, that the impact of all of the combined social determinants of health factors, the 5 factors, results in an overall increase in the readmission rate of about 0.6%. And then we have Brunswick County, where the readmission rate is right around the average, a bit higher, but we actually see that based on our model, the impact of social determinants is driving that readmission rate down. So we might expect to see a relatively higher readmission rate in Brunswick County, but the social determinants factors seem to be actually lowering that readmission rate. And here we can see the same information just displayed graphically, so we can really highlight where these counties are different in terms of the impact of each of the 5 SDOH domains. And now we get into some snapshots from a Tableau dashboard that we built for this proof of concept. And so the first dashboard looks just at overall readmission rate for counties nationally. Here we've zoomed in on North Carolina. And when we hover over a county, we can look at not just the readmission rate, but similar to the prior slide, what is actually driving that readmission rate, looking at each of the 5 key domains of SDOH. Again, this is started as a national dashboard. So here, looking at readmission rate, the darkest green identifies counties where the readmission rate was much lower than the national average. And counties in red, we see, especially we see Pitt County and Greene County, some counties that have higher just readmission rates relative to nationally. But in the next slides, we can actually look at what may be driving that in terms of social determinants. So starting with environment. So looking at how does the environment of the county, things like this, this is kind of looking at urban versus rural. How does that impact readmission? And we can highlight some of the counties, at least in North Carolina, that seem to have feel the impact of that particular SDOH domain. And we can look at economic stability, and that does seem to be impacting counties in North Carolina a bit more. So here we looked at the county poverty level as well as some other related variables, and again came up with a composite score to across those several variables measure the overall level of economic stability. And what we see is we have some counties where there's the impact of economic stability, in this case higher poverty, is leading to higher readmission rates. Again, for each slide, we've kind of highlighted the top 5 and bottom 5 counties in North Carolina. We looked, again, comparing nationally across the US. So some of these things impact North Carolina and some really don't. Here we're looking at professional employment. So the key domain here is education. So we looked at some basic measures of education, but also looking at what percent of people in the county are employed in professional settings. And we found that the impact of that, more people, higher percentage of people in these sort of professional jobs leads to lower readmission rate. And we do see some counties like Wake County where that seems to be apparent. And then finally, access to health and healthcare. So we just looked at number of hospitals and number of doctors. And you see these counties in North Carolina are all sort of in the middle. So this doesn't seem to be a huge impact, at least compared to nationally, the impact of health and healthcare in North Carolina. But we do see some differences across counties here. And again, this is looking at the neighborhood and built environment domain. Again, we see a couple counties stand out, Durham and Wake counties, where a more urban setting seems to be associated with a higher readmission rate, at least based on our model. And finally, we have social and community context. So some of these we found, obviously they're kind of related to each other. So in this case, we're looking at social and community context as more or less diverse counties. And we can see a slightly different view here where we do have some counties in North Carolina where these more diverse counties seem to be associated with higher readmission rates. And as I mentioned, we know there are a lot of different directions we can go with this, and we look forward to kind of expanding it. But just wanted to share some initial results of what we've found so far. And with that, I'll pass it back to Anne.
We did. There we go. Thank you, Dan. I find it fascinating that patient care has, it's a socioeconomic and it's a holistic view of patient care. It's just not clinical. We really need to take a perspective of the socioeconomic issues resulting to impact patient care. Oh, I apologize. I'm on Dan's screens. Give me a minute here. Let's scroll down to. Can everybody see okay? Is that good?
Yep, that should be
Looks
good.
good.
Thank you. I apologize for that. So I really find it fascinating. And I think as we go back into looking at how we integrate populations, the North Carolina population with telehealth and social determinants of health, we really need to learn how the industry is using the dynamics of telehealth in this expanding platform for patient care and managing patient care. We did some research to understand the practitioner and the patient experience with telehealth, and knowing that its success would not just impact the current state of healthcare consumption, but the quality of the future. We learned about the current dynamics with COVID-19, as well as what we believe is required for telehealth to endure beyond COVID-19. First, the physician specialties and therapeutic areas really matter. Stay-at-home restrictions remain in place. We're slowly seeing the composition of telehealth diagnosis mirror that of the broader population. Hypertension, diabetes, and the like will make their forefront, like Dr. Chestnut had said, with endocrinology and diabetes. We will actually start looking at underlying patient dynamics, as it was certainly more complex. Patient age, underlying conditions, and geography all play a role, but so did internet access and technology. Younger patients are rapid adopters to telehealth. They just feel much easier. It's like a natural extension to their digital life. And many of their conditions are very easily and readily supported remotely. But let's look at the older population. It's a little more complicated. Many are afraid of leaving their homes, a fear of getting the virus. So it has also been difficult for many of the elder population to acclimate to technology. Patients in rural geographies are thrilled not to have to come in and drive in for their specialists, but it's the rural areas that lack the technology of internet connectivity required for the video visits, which brings us to our thoughts about the future of virtual care and what it will take. I think treating conditions that require hands-on diagnostics, like feeling a lump, a swollen lymph node, conditions that require base diagnostics like an EMR or MRI, those will remain some barriers for pure virtual care, thus requiring us to consider a hybrid model. Products administered in the office, such as vaccines or specialty drugs and infusions, will also need to find their way into the patient experience of virtual care. For practitioners, payment parity will need to be continued for COVID-19. Without this, we might see the utilization retreat back into pre-COVID levels, was at roughly at 1%. It's all about optimizing the virtual care workflows to be at parity, if not better, than the office visits. There's little doubt that the opportunity for value-based virtual care is here. It's tremendous, but we need to capitalize on its current momentum. The telehealth experience needs to be improved. Caregivers are finding new and creative ways to move between personal and virtual care. This slide basically shares that the future of virtual care is integrative. It's going to integrate value-based care. It's going to integrate preventative medicine. It will adopt more therapies. It will require more intervention. It will require the use of technology and data so we have better diagnostic skill sets. And it will drive cost and efficiencies, even data sharing and transparencies. Virtual care will be a contributor in the total continuum of care delivery. This is just an overview of our digital health solutions that we've designed to improve unique aspects of the healthcare continuum. Digital health products are now being available to provide services to you and bringing a greater scale of efficiency, access, convenience, and patient engagement. And just a note, I think before we close, on taking some, to just point out that we all understand that this COVID has really affected our organizations and experiencing a substantial drop in some of our revenue as the industry shifted from the elective services, concentrating on providing care during this pandemic. These financial shifts have forced us to rethink our strategies and our plans. To support that, we have provided that state scorecard, which we demonstrated earlier in the presentation, providing the measures to show weekly performance as well as qualitative information about key dates for your state. If you're interested in any of these offerings, just simply let us know in the polling survey following this presentation. And I think the final thoughts here is basically that the economy and poverty has been the biggest driver for some of our readmissions, and the inclusion of social determinants of factors really play an impact part of in managing the outcomes of patient care for the population of North Carolina. The top counties that were negatively impacted in the total impact combined social determinants of health were Pitt County, Durham County, and Wayne County. The top counties where social determinants of health based on poverty were most affected were Halifax, Hertford, and Columbus counties. So social determinants of health factors do impact readmission and the overall population health of North Carolinians. Ann Johnson, who is the CEO of the American Telemedicine Association, says that virtual care has a three-part mission. One is to deliver care where and when people need it. Second, to assure that it's safe, effective, and appropriate. And three, to enable clinicians to do more good for more people. We really want to share, as we close, a patient experience on the effect of telehealth in your population. Terry Siegel is a 69-year-old in Charlotte, North Carolina, and she needed to go see her urologist, but was really nervous about leaving her home due to the risks of the coronavirus outbreak. So when the urologist's office called her last week to see if she would be open to a virtual visit, she was relieved, but she had never actually experienced a telemedicine visit before. A few days later, the video came, the application on her cell phone. She connected with her doctor. They assessed and had some questions about her symptoms. She was prescribed medication. And she said it just didn't feel safer. It was so much more convenient for her than an in-person appointment. It takes like 15 minutes for her to travel, to get in her car. It took almost a half an hour to wait in the office. So she was basically saying it took a half a day for her usually to go into to do the office visit. So we believe virtual care will continue to be a journey. We feel that it's really been affected and improved by the conditions of this pandemic. We know virtual care is transforming. We're going to be able to identify diseases and use data and technology to help support our caregivers doing virtual care visits. And also, I think we need to focus, when we focus more on prevention, we create a more patient-centered focus where patients are playing a much more active role, and telehealth allows that. And also, I think social determinants of health will also help provide a more holistic perspective to the needs of our patients. With that, we thank you, and I'll turn this back to Dr. Chestnut.
Thank you for that, Ann and Dan. We welcome questions through the Q&A. Do we have any questions, Danielle? I think you're on mute.
Yes, we do. And it looks like Dan is also trying to help answer these in the chat as well, or in the Q&A as well. So we had one question about what was included in the claims. And also if you looked at Western North Carolina counties.
Right. And so in terms of Western North Carolina counties, we were a bit limited in this case. We tried to limit our model to counties where we had a minimum number of patients where we felt comfortable we could accurately measure the readmission rate to include in our model. We've talked about how we should really expand that. And so we feel pretty confident we could expand this out to include all counties in North Carolina. And I guess going to the other question, so it might be best to take it offline a bit to share some more detailed information about IQVIA claims data assets. Really, that's kind of a core business of IQVIA, housing these larger claims data assets. Our LRX data has very high coverage across the U.S., including all states. That comes directly from pharmacies, so we're very well covered there, as well as our DX data, which comes from doctors' offices. The probably limiting factor in this case was what's called our CDM data, which happens to be a smaller data source, but it provides a lot of detail around hospital visits, things like what was prescribed within the hospital and more detail about what happened within the hospital setting. In the end, for this particular proof of concept and the time frame that we used, when we link all of those three data sources together, our sample size in some of those western counties was a bit smaller than we wanted. Again, this is another direction we'd like to go, is just to try to expand this out, include other data sources so we can kind of populate that full map. In terms, I guess one more thing, it's funny answering questions and you can't see if they're nodding or not, but in terms of EMR, we do have some EMR sources within IQVIA that we could pull in, but we also would like to, find some clients to partner with to kind of use IQVIA claims data expertise combined with some EHR from a client, and see if we can combine the two to really come up with a best solution here. I'll leave it at that for now. But do feel free to reach out either within the chat or afterwards to discuss in more detail.
Thank you, Dan. Do we have time for the polling, Danielle?
Yes, absolutely. That was going to be my next, and actually we just had another question come in as well. So I will let you guys answer the question while I set up the poll. So what items are you or could you look at to gauge quality of care in a virtual visit?
Well, let me see. I think what we would be gauging on is basically looking at your overall number one, gaps in care as a measure of improving performance, as well as data and analytics. The data that's actually used to help the patient become more engaged, a digital health platform, a remote monitoring platform. I think looking at your process and systems to actually be able to guide your care management team to actually integrate the right workflows for each disease-specific or comorbidities to help them integrate that workflow into a virtual care visit, education and guidelines, and then supporting the patients to have accountability and engagement. Through apps, remote care monitoring actually can integrate apps like app scripts. We have tools that actually integrate so that we can actually help the patients engage and improve and monitor their own care. Is that helpful?
Thank you so much for that. While that is going, you should all see a poll up on your screen. It's very brief. It's only 7 questions. So we'll give you all just a few minutes to go through and answer those. This is just giving us a little pulse point on kind of where everybody is at. And we'll give it just a few minutes and then we'll be able to share those results. And while you are all answering, another question has come in. Would you say, based on your assessment, that social determinants of health appear to contribute significantly to readmissions?
Yes, yeah, we would say that, and we found that also in research. Similar types of studies that others have done, that that it really does seem to have an impact. In our proof of concept, we saw that overall average impact, but certainly there were counties that stood out where it seemed clear that there was some impact. And as I said, this sort of matches other research that we've been reading and looking into that tells a similar story.
Thank you. It looks like I don't have any new ones that have come in. Oh, I lied. There it goes. Do you have a ranking of the impact of social determinant domains on readmission rates?
Yeah, and so why don't I try to share my screen again. I can go back, and maybe I went a little too quickly through this slide. And so we did kind of look at least within our model. And again, we feel like we could improve this model. There's a lot more we can do. But we did look to see what was the overall impact on average of each of the 5 domains. So we have them off to the right. And this is kind of looking at just the absolute value of the impact of the domain, and just averaging that. So for example, for neighborhood and built environment, at least in our model, seem to be the biggest driver relative to the other 4 domains. And we would say on average that the impact on readmission rate was about 0.27%. Again, some counties much lower, some much higher. Whereas we see, and so the color also indicates sort of the direction. So in the way that we measure that domain, is it driving, as that domain, the measure increases, is it driving readmission rates up or down? And so we see on the other end, health and number of hospitals, access to healthcare. We see a relatively lower impact nationally. Again, this is all national. I would say based on our research, it seems like the impact could even be a bit higher. And as we kind of expand this out and include more counties and more data, we might find that, but for now, this is kind of based on our initial model, what we're finding.
Excellent. And another question has come in. How do you define diversity?
Yeah, so this was, and I'd have to go back. So it was collecting from these public sources like census and CDC and some other places, public information about all the different counties. And I think that we had several variables that are all kind of around ethnicity. I think we also looked at percent of families that were women head of household, with and without children in the household. So we looked at kind of a variety of underlying variables and tried to come up with this composite score using principal components analysis. And then kind of the process is to compare the correlation of the underlying variables with the composite score to try to come up with some interpretation of what that component really means when it's really sort of a combination of maybe several underlying variables. Off the top of my head and in this presentation, I don't remember specifically which variables we looked at for that particular domain.
Thank you so much. I'll say it again and we'll see if we have any more sneaking a question in. I don't see any more currently in our question and answer. And it looks like we're good in the chat. Again, just a reminder, if you guys can take just a quick second to go through and answer the polling questions. If any don't apply, you can just put not sure. That's totally fine. And we'll give it just one more minute on those poll questions, and then we'll share those results with you all.
And Danielle, just to highlight on the polling, I did have trouble with the submission, but if you put not sure to that question number 2, then you can submit easily.
Yes, apologies for any confusion.
We're all learning to do new technology.
Oh, yes. Great. Looks like we're getting a couple more answers coming in. There we go. All right. I'm going to go ahead and end it just so we can all go ahead and look at the results and just get a good pulse of where things are. So let's see here. Alrighty. As we can see, it looks like most everyone is already using some kind of telehealth, telemedicine. And yeah, that looks really great that, you know, a lot of your staff have the know-how and capabilities to implement that telehealth and telemedicine there at your different facilities. Let's see, looks like, again, good majority using social determinant platform tools or related services, or will be within the next year or so. Again, great knowledge of staff with the know-how of getting that all situated. All right, great. And we'll be sure to share these results as well after all of this with all the other materials in case anyone is interested.
I'm very excited to see that social determinants of health has played such an integrative role in managing patient care. We have a holistic approach, you know, that we really need to include in managing patients. And it's really nice to see that everyone, 44% is actually enhancing and using social determinants of health data.
Yeah, very great. Alrighty. All right, and I will turn it back over to Dr. Chestnut now.
Great. Thank you again for a wonderful presentation with lots of good data that we were able to review. Thank you. So next, I'd like to introduce our next speaker, which is Chris Pagano from Vizient SG2. Chris is a Senior Director for Virtual Health and provides guidance on the implications and relevance of virtual care in the health industry. He has extensive experience helping healthcare entities plan for the future. So we are excited to have him join us this afternoon virtually to give us a great presentation. So I'll turn it over to you, Chris.
Lovely. Well, I definitely appreciate that. Were we able to pull up the slides, or should I pull those up on my side? I can certainly do that if you'd like.
I think if you could share your screen, that seemed to work great earlier.
Okay, great. No problem at all. Give me 1 sec. Let me get that kind of set up here, and we can definitely do that. No worries. Hopefully everybody's doing well. Obviously, I'm thrilled to be able to follow such a fantastic discussion that we just came out of here. Obviously, social determinants of health, as you were saying, is an incredibly important area that I think everybody in the digital space either is focused on or certainly should be. Thrilled to be able to follow that. So you would think I would be the most expert at this, but here we go. All right, can you all see my screen?
Yes.
Lovely. Okay, let's give this a whirl. So today what I want to do is spend a little bit of time discussing kind of where we are within the virtual health landscape, a little bit about where we've been over the last year or so, and perhaps where we're going as well. I find though that it is frequently beneficial to level set a little bit on nomenclature, because there's so much terminology that we hear in this space, right? We hear telemedicine, we hear telehealth, we hear e-health, m-health, remote patient monitoring. But at SG2, we actually utilize the verbiage virtual health, and we define virtual health quite broadly. And we do so by design because really our goal is to encompass as much of that terminology as we possibly can. Because the reality is that, frankly, it's not about the terminology, right? Frankly, it's not about the technology either. The technology is simply a tool that we utilize to facilitate different types of interactions. Now, those interactions, of course, may be physician to physician in nature. They may be patient to physician in nature. They may even be patient-led. But ultimately, the goal is one and of the same, to deliver convenient access to high quality care. Now, of course, this is an area that, we at SG2 and certainly many leading organizations across the country have been following quite closely for many years. And frankly have been championing and trying to help organizations to move towards for several years. But nobody anticipated COVID, of course. And so what's really happened is we've moved about 5 years into the future when it comes to the degree to which these types of technologies are being utilized. Of course, obviously, when we rewind the clock here a little bit, look back at kind of what happened in March, we all know that we saw this very precipitous drop in-person E&M visits, and correspondingly saw a very dramatic rise in the utilization of virtual health, again, over those initial few months. I'm sure, as you are well aware, we've seen some of that pull back over the last handful of weeks, but we still see it pretty steadily in the mid to high 20s at a national level. And frankly, there's a huge amount of variability from organization to organization. So there are still organizations here who are sustaining very high visit volumes based on that initial spiking that you saw, again, back in the first few months. These are a handful of organizations that saw some of that spiking. I can tell you firsthand that many of them are still experiencing very, very high visit volumes. I literally just was on the phone with another client, large AMC up here in the Northeast. And they were letting me know that they're still doing upwards of 3,000 visits or so per day in terms of virtual visits. So very, very strong visit volumes are maintaining here, even despite the fact that in some regions we've seen some of that visit volume go back. When we think about what that visit volume is really comprised of, though, there are really 5 areas where virtual health has actually been able to address the needs of different hospitals and health systems across the country. So, of course, the first during COVID has been triaging, right? So really understanding which patients really need to be seen immediately and which patients perhaps could defer care or perhaps not even necessarily need to receive in-person care, could shelter in place. Being able to do that utilizing virtual urgent care clinic capabilities, e-visit capabilities has been tremendously effective and allowed organizations to be mindful of their overall clinical capacity. We've also, of course, been very interested in the utilization of virtual health to support non-COVID-19 patients as well, right? So we have patients out there who, yes, they don't have COVID, which is great, but they also are very uncomfortable coming in for in-person visits. Oftentimes, these are chronic care patient populations, may even be immunocompromised, right? They're at risk, and they're not getting the care that they really need on a consistent basis because of the current environment that we're operating within. And so virtual ambulatory clinics have certainly picked up the ball there and been able to allow organizations to provide the ongoing care that these patients need, maintain that care continuity, that physician-patient relationship, and allow these patients to receive the support that they need in a way that feels safe to them, meets their needs, and doesn't put them at undue risk. So definitely huge utilization here. Of course, it's not just about protecting our patients, but it's about protecting our frontline workers as well. And so we've certainly seen teleconsults provide a huge amount of value in that space, as well as bolstering the overall clinical capacity, right? So we've seen asymptomatic clinicians be able to continue to practice by practicing virtually. We've seen retired clinicians come back into the workforce, but only practicing virtually. And even given some of the regulatory changes that have happened at the state level, we've seen out-of-state clinicians be able to practice across state lines without having to get a secondary or even tertiary license in order to deliver that care virtually. So tremendously valuable in that area. And then the last one has been remote patient monitoring, right? So being able to keep tabs on patients in an asynchronous way where you getting visibility into what's happening with these patients. And then if appropriate, you can act proactively through a virtual visit or some other type of outreach to ensure that these patients are being able to receive early interventions and taking a more preventative approach to care management here as well. So through all of the utilization that we've seen this also drive a shift in physician attitude as well. So the reality is that historically physician buy-in has been tremendously challenging. I'm sure many on the line have had that experience firsthand, but many of these physicians have had their hands forced as a result of COVID. And what's been great is that we have seen actually a tremendous increase in the percentage of physicians who have actually used virtual health to deliver care to patients over the last couple of years. And the vast majority of this shift has actually occurred over the last 6 months or so. And hope, I would say perhaps not consistently, but increasingly we're seeing that physicians are actually finding that it turns out virtual health is incredibly valuable, and they're starting to recognize the value that it brings not just to patients, but frankly that it can bring to themselves as well. And that's very much in line with the changing consumer attitudes we're seeing as well. So we've seen that patients are increasingly preferring virtual and specific episodes of care to more traditional settings. You can see the survey work that we did here in terms of asking a very large patient sample as to whether or not they would want to receive care for a minor illness at a virtual site of care versus more traditional sites of care. And you can see the results that overwhelmingly they do prefer the virtual visit over a traditional physician's office visit. And the one that really actually jumps out to me is the disparity here in terms of the preferences for the telehealth visit versus the freestanding urgent care center. So the fact that 58% of individuals surveyed would prefer the telehealth visit over the 5% who would prefer the freestanding urgent care center as the site of care for that low acuity visit, to me is quite remarkable and really may indicate a pretty significant sea change that we're seeing occur in real time. We've also seen that patients have expressed pretty consistently that they like virtual health overall, right? So among those who have used virtual health, 82% report that they like virtual health. Among those who have never used virtual health, 61% report that they like the idea of virtual health. And so on a whole, 68% of individuals across the country say that they like virtual health. And what's even more compelling is that they are reporting that they are not just thinking about this in terms of COVID, but they're thinking about it in terms of overall care delivery. So 80% say that they're likely to use virtual health services post-COVID. 53% of those who have never used it say that they're likely to use it at some point post-COVID. And then again, the overall roll-up here is 62% of all Americans feel, these Americans feel that they will use virtual health services at some point in a post-COVID environment. So that really very much supports our overarching projections as well. So for those of you who are not familiar with the forecast that we put out every year, we spend a very significant amount of time. We do a pretty exceptional amount of analysis and take a look at some pretty significant data sets to indicate where we think things are headed here. And so from a virtual health perspective, the future looks quite interesting. So the first line you see here is our all visits forecast. So this green line, you see that initially you have a negative 29% decrease in all visits. So these are all E&M visits across both virtual sites of care as well as more traditional brick and mortar sites of care. That first year drop, that's COVID, right? No surprise there. What we do anticipate though is that we will see some modest returns over the next couple of years and then relatively incremental but steady growth out through the end of the decade, ending at an increase of 9% by the end of the decade in terms of all visits. Where this gets more interesting, though, is when you pull out the virtual visits and just look at the brick and mortar visits. So this is the blue line. So that is your negative 55%. You see that precipitous drop in brick and mortar visit volumes only. That, of course, again, is COVID. We do anticipate that due to obviously deferrals of care, some of that care will come back over the next couple of years or so. But we then do anticipate relatively steady, albeit incremental, declines out through the end of the decade, ending at a negative 39% decrease in all brick and mortar visit volumes. So where are those going? Well, a lot of those are going to the virtual space. So you see the precipitous increase due to COVID. We anticipate that we'll end the year somewhere in the neighborhood of about 36% of all E&M visit volumes across the country occurring virtually. Now, I want to point out here, this is an annualized forecast. So underneath these annualized numbers, we did account for secular spiking that we are seeing across the country in terms of visit volumes going up and down and back up again, and so on, due to changes in policy. Obviously they've gone down a little bit more recently in terms of some people coming back in for in-person visits. But as we've seen COVID spiking occur, we've of course seeing corresponding increases in virtual visits occurring as well. Again, correspondingly to the next couple of years, you can see the pent-up demand aspect of the brick and mortar visit forecast does actually lead to a drop in the virtual visits. But then as the payment and regulatory landscape continues to evolve and solidify, and then the increasing evolution of different emerging technologies coming online in parallel to this, we do anticipate relatively steady growth out through the end of the decade, albeit a little bit incremental towards the back half of the decade, ending at about 43% of all E&M visits across the country occurring virtually by 2029. So very, very significant increases in virtual health utilization overall. And what that underscores is the fact that we've really entered into a new digital era of care delivery. So these are no longer assets that are nice to have. These are needs to haves. These are core to care delivery moving forward, and really are going to be a necessity in terms of meeting the changing expectations of patient populations across the country. So when you think about, well, what is this going to mean from a virtual health perspective moving forward? You've made significant investments, many of you, in different virtual health assets, specifically to meet the needs that COVID has brought upon us. But how does that translate moving forward? Well, the great news is the investments that you've made are actually the foundational elements that you will need in terms of your core virtual health capabilities moving forward as well. So your virtual urgent care clinic is going to support your low acuity patient populations in terms of improving access to care, perhaps supporting a growth strategy, and overall helping you to be able to provide that low acuity care in a convenient fashion. Your virtual ambulatory clinic capability can be utilized to increase access for existing patient populations, in particular chronic care patient populations, as well as to help you to shore up your balance sheet from a margin management perspective, moving some of that pre-op and post-op work out to the virtual health space, especially for those of you who are at risk or participating in different types of risk-based contracts. The teleconsult capability, of course, expands your reach to different specialists. The classic examples here would be your EICU capability, of course, your telestroke capability, telemental health. We've seen teleinfectious disease becoming much more prevalently seen in this space, as well as tele-MFM. So maternal fetal medicine, that is a space we have very, very significant shortages of maternal fetal medicine specialists. So that is an expanding space as well. Again, a lot of these capabilities work in conjunction with one another. So your virtual primary care capability, your remote patient monitoring capability, all of this comes together to really support your chronic care patient populations overall and allow you to provide that more proactive level of care delivery moving forward. So how do you actually accomplish some of this, right? So what is some of the execution? Well, to us, there are three critical areas that we feel need to be prioritized. And the first is managing the workflow. So it's critically important for organizations across the country who are standing up virtual health capabilities to recognize that the technology is only a component of the overarching programmatic solution. So how do you make sure that as you stand up these platforms that you're addressing charting complications, that you're making sure that you're working with your clinical leadership team to solidify any changes around clinical protocols that will be necessary to utilize the virtual health platform appropriately. How do you make sure that your patients are aware of those offerings, that they know how to use them, that they know when to use them, and that they're high quality care, right? The reality is that while certainly we've seen a dramatic increase in the percentage of individuals who have experienced virtual health, the reality remains that a lot of people still don't have any experience with virtual health. They don't know when to use it. They don't know what the scope of care is. They don't know that it's high quality care. So what processes do you put in place to ensure that you're providing that level of patient education to help them know how to use it and again, when to use it? And then adjusting your staffing to ensure that you're allowing your clinicians, especially as we experience clinical capacity contraction, to work top of license. So how are you utilizing your advanced practice practitioners? How are you utilizing your physicians? How are you adjusting your operations? Does it make sense to continue to have 15-minute time slots in your primary care settings? Maybe yes, maybe no, depending on your strategy. How are you thinking about your compensation models here? Are you going to provide compensation to your clinicians regardless of what the reimbursement landscape looks like in the short run? These are important questions to ask yourself and make sure that you're, again, shoring up all these details, because this really is the differentiator in terms of organizations that have success in the space and those who struggle. From a technology perspective, how do you ensure that you're not just standing up a robust technology that actually isn't going to be valuable because it's running on a insufficient broadband infrastructure? So looking out to the community, understanding where there may be broadband limitations, especially in underserved communities, and how do you design around that? How's your Wi-Fi within your organization? For a lot of organizations, unfortunately, a lot of organizations, the answer is it's not great, right? So these are important areas to focus in on as you're building out your overall digital infrastructure. You're going to have a huge amount of data coming in to your organization from all these new touch points. How do you ensure that it's being managed in a way that is safe and secure, and also is going to be informing not only care decisions, but strategic decisions at the enterprise level moving forward as well? And then finally, how do you leverage these virtual health capabilities to broaden your reach out into the community through perhaps the formation of different types of innovative partnerships? How do you ensure that these are actually helping patients to be able to come in to receive your overall portfolio of services, as their needs change from a clinical perspective as well? All of these are strategic opportunities that you're going to want to consider. So in order to be able to approach any of this, you really need to take a step back and really understand, who are you as an organization from a virtual health perspective? Are you an organization who's an aspiring organization? You probably hadn't done a lot of virtual health pre-COVID, but you stood up some platforms now. You don't have very much governance structure or digital infrastructure, but you're starting to try to get your arms around that. Or you were an emerging organization, one who had invested in virtual health pre-COVID. You scaled it up during the COVID period, and now you're continuing to advance your strategy in the virtual health space and shoring up some of the limitations that you've had historically. Or are you a sophisticated organization? One of the few organizations across the country that was early to invest in virtual health. You're now pushing the boundaries of what virtual health can even do, and you're starting to incorporate various emerging technologies as well. Once you realize who you are as an organization, then you'll recognize that there are actually certain initial activities that everybody's going to need to do, and then there are going to be some that are going to be specific to who you are as an organization. So if you're an aspiring organization, you want to make sure that if there are any gaps in those initial 5 areas that we mentioned earlier as core virtual health capabilities, that you're addressing those early on. If you are an emerging organization, how are you going to actually continue to expand your virtual health portfolio and again, shore up that overarching digital infrastructure and your governance overall to make sure that you have a viable virtual health program moving forward? And if you're a sophisticated organization, are you perhaps taking a national approach now, right? You're going to enter into new markets that you never have before, and you're going to actually be looking to take a more national perspective in terms of your overall virtual health program. And then additionally, the opportunities that are going to be in front of you are going to be dependent on who you are as an organization. So if you're an aspiring organization, you probably want to start looking at well-established vendors. If you stood up platforms that were non-HIPAA compliant because of some of the rule changes we've seen, those are not going to remain in place. That's going to get pulled back. And so you want to make sure that you have a well-established virtual health vendor in place that's going to be able to support all of your diverse needs across the entire enterprise. If you're an emerging organization, you're really looking into trying to utilize the virtual health platforms that you've already adopted. You're scaling up your telestroke program, you're scaling up your EICU program, and perhaps utilizing those platforms here for your telemental health program or your teleinfectious disease program, or even your tele ortho program, right? There's no end to the opportunities that are in front of you. If you're a sophisticated organization, how are you incorporating artificial intelligence into your virtual health capability? How are you thinking about leveraging virtual reality and augmented reality? What does the overarching acceleration in the Internet of Things space going to mean for you as an organization? These are all important questions to be asking yourself, because really where this is all leading towards is this overall digital future that we were discussing earlier. And the impact is quite dramatic, not only in terms of facility design, but it can mean that there are going to be changes to your physical footprint and your overall system of care as well. So when we think about the concept of digital capabilities being interwoven into the DNA of care delivery moving forward, you see here our flat system of care to start out with. And you can see a selection of different digital capabilities that are on the market today and that are available for you if you wish to pursue them. And depending on how you adopt these and which ones you turn on, it's going to have an impact on the acuity level that can be delivered can be managed, I should say, at different sites of care. So in this example, you can see now that the acuity level that can be delivered in the home is more in line with the ambulatory procedure center, the urgent care center, the diagnostic imaging center, and the physician clinic, all of which can now handle that level of acuity. And that's a level of acuity that they can handle that would frankly traditionally only be seen in the hospital. Right, so it really has a pretty significant impact on what does this mean to how you're going to be investing in your physical sites of care here moving forward. Similarly, the same concept can be applied to partnerships. So depending on the partnerships that you decide to pursue, in this case, an employer strategy, you're partnering with a pharma, you're partnering with a well-established AMC, and you're going to bolster your post-acute care capabilities through a partnership as well. You can see that there's a different impact here on your system of care. So we're starting to get into a discussion around what are the broader strategic implications of these types of technologies and different types of possible business arrangements that you may decide to pursue. And this can get as complex as you'd like. So the real outsized impact here is when you turn on actually both sets of capabilities. So if you're pursuing a strategy in the digital health space, and again, in the spirit of turning on both sets, you're pursuing a partnership strategy, you can see an outsized impact here. And again, this can be extraordinarily sophisticated depending on how you decide to pursue this. So as we kind of wrap up our conversation here, a few questions to leave you with to have you think about this a little bit. So how will virtual health impact the recruitment and retention of your physicians and your clinicians moving forward? As we just got done discussing, how will your virtual health capabilities impact your physical footprint? What is this going to mean in terms of the redesign of your facility planning as well? So what percentage of care moving forward is going to be done virtually versus in person? What does that mean in terms of how you structure your exam rooms? How many exam rooms do you actually need? Or could some of those perhaps be repositioned as virtual health booths? Are you going to still have a waiting room? Right? Or are you going to go towards a contactless experience? Are you going to still need to have some of the individuals up front who are doing your scheduling? Is that whole kind of scheduling area, is that scheduling area going to still be there or not? Because if your patients are leaving without having to actually set up that follow-up visit, because they're going to set up that follow-up visit through an app, there's some interesting questions there that you may want to think about. How will you evaluate various virtual health platforms? There's no shortage of opportunities in front of you. So how do you decide where to actually allocate your resources and ensure that you're realizing an ROI moving forward here in terms of your technology investments? And then finally, how will emerging technologies further accelerate the shift to virtual? So as we talked about during the forecast section of this discussion, certainly the rise of different emerging technologies, it opens up new opportunities on the virtual health side of things in terms of what can actually be done through a virtual health capability moving forward here as well. So with that, would love to open up the discussion to questions or any items that you would like to explore further.
Great. Thank you so much, Chris. We do have a couple of questions that have come in. So the first one is, what are your thoughts on sustained reimbursement for virtual care?
I am not surprised to get that question. So I'm gonna try to make it so I can actually see people. So sustained reimbursement. So here's where the reimbursement landscape we think is going. There's a couple things here. So the first is, for chronic care patient populations, it is almost assuredly the case that there will be substantial reimbursement for those individuals. So it is widely understood that patients like virtual health, we know that we can actually manage these patients in a more comprehensive way that bends the cost curve down and actually leads to high quality outcomes. So from a CMS perspective, who, by the way, we speak with frequently, we have a whole team in Washington. You know, we have the opportunity to speak with congressional leadership on both sides of the aisle. So we have a pretty decent beat on this. There is broad, wide-ranging support for that. And you've seen that through the legislative changes and regulatory changes we've seen over the last handful of months. From a low acuity perspective, there's a little bit more concern. So not to get too far into the weeds here, but kind of need to with this. The reality is that there's a little bit of a discussion here around interpretation of data. So what we've seen is that from a low acuity perspective, the visit volumes that have occurred virtually are higher than what we would anticipate we would see through a traditional in-person visit, right? So there's two different ways to interpret that data point. One is that, well, this is inappropriate utilization. This is fraud, perhaps even. And so we need to kind of buckle down on that and get our arms around it. The other way to look at that data is that our historical system has actually inappropriately suppressed access to care for those low acuity conditions for a lot of individuals. And now that has been removed, right? And so you see this dramatic increase, not because it's inappropriate utilization, it's actually completely appropriate utilization. It's just not utilization we would historically see. We don't know the answer yet. So what we're waiting to see here is that for a lot of patients, what ends up happening is that historically they would defer care out to a later point in time and end up in the emergency room. We don't know if that is going to happen yet, right? Because there's a time factor there. We haven't seen that time factor kind of there play out all the way. We think we know because we have seen ED visits drop precipitously. The question is that because of COVID or is that because of virtual health or some combination of the two? So I can tell you that CBO, unfortunately, is taking the stance that they think it's inappropriate utilization and perhaps fraud. And so they're looking to pull that back. And so we do anticipate that on the low acuity front, not that there will be a removal of coverage, but probably the reimbursement level will get pulled back a little bit there. Lastly, though, and this is the last point I want to make on this, there's a broader context to this discussion, which is what we're hearing consistently is that it is not lost on anybody that organizations who are more highly capitated have performed better throughout the spring and the summer than those who are more highly fee-for-service. And so it sounds like from everything we're hearing that regardless of what happens in Washington in the fall, it is very, very likely that moving forward into 2021 and beyond, we will be moving towards a more highly capitated model. And we see the beginnings of that with, you know, the CMMI rollout in terms of that alternative payment model that was put forward a month or so ago. And we certainly anticipate that we will see more value-based opportunities here moving forward as well.
Great, thank you. Next question, which is a two-part actually, so we'll do part one first. Can seniors utilize various platforms or technology? In my experience, some have difficulty or lack of access to tools required for virtual visits.
All right, so there's two parts to that question actually underneath all that. So I'm going to separate this out just a little bit. So the first part of it is, can seniors use it? What you're really asking is, can older individuals navigate the technology? And the answer to that is a design issue, right? So what I can tell you is this, and I'll sort of skip to the end here in the interest of time. If I were to ask you, who is the patient population or the demographic that clicks on advertisements for virtual health capabilities more frequently? The answer is 65 plus. It is not millennials, okay? So interest in virtual health is very high. And it actually makes sense, right? Because those are the individuals who actually interact with healthcare most frequently. However, the most frequent utilizer of virtual health, so actually does the visit, is the 29 to 35-year-old female. So why is there a gap? Well, the reason that there's a gap is a lot of these technology solutions are not actually built in an intuitive way. They are hard to use. And the reality is that for those who are not digital natives, the more challenging you make the platform to navigate, the less likely it is that they're going to be able to troubleshoot on the fly and actually be able to manage that capability and do those visits. That's where we see the problem. So where there's a very significant need and opportunity is actually to think about user-centered design and design for the needs of the patient population you're serving. And if that's going to be the elderly need to have that be as intuitive as possible. And it may mean that you need to bake into your overarching program additional levels of support on the IT front, additional levels of setup. These are part of the programmatic elements that you may need to stand up to make sure that that is actually a usable solution. The other part of that question was, do you have the hardware and software? That's actually a broader conversation than the older patient population. That's actually a conversation around underserved communities. And this is a big problem. So one of the big conversations a lot of people talk about is how virtual health capabilities can actually help overcome some of the what's the word I'm looking for? Healthcare inequities that we see, right? So disparities around outcomes that are driven by social determinants of health, which we obviously talked about earlier. The only way that that works is if you have the corresponding digital infrastructure in place, you have the corresponding hardware in place, iPads, cell phones, laptops, and not all those communities have that. So again, understand if you're going to set up these types of capabilities and be targeting that type of patient population, you need to account for that and bake that into the overall offering.
Yeah, absolutely. Okay, part 2 is vital signs, another struggle for this person's particular organization, trying to figure out a way to get them easily as they're one of the cornerstones of a typical clinician visit.
We got to be more clear about when we say vital signs, what are we talking about? So if we're talking about wellness visit, that's one conversation. If we're talking about remote patient monitoring for chronic care patient populations, it's a different conversation. Is that individual able to provide any clarity real quick on that? Or you can even jump them off mute and we can chat directly if you'd like.
Yes, give me one moment. And
Sorry, I didn't mean to make that harder, but
no worries at all.
The appropriate answer.
Adam, I am going to allow you to talk. You don't have to come on camera unless you want to, but you should be able to unmute yourself now.
Hey, thanks so much, Chris. Can you hear me?
Yeah, Adam, how are you doing?
Yeah, so I work in a kind of value-based organization that takes care of Medicare patients, so you can kind of see where I'm coming from this. And I see patients almost every day. We try to manage very sick COPDers, CHFers, et cetera. Yeah. We have home telemonitoring that we do, which is through a platform that we contract with, but we're moving towards doing more virtual care, just getting vital signs. So if I want to expand this to a primary care population in seniors, and I want vital signs as part of my typical clinician visit with, I think Martha would agree, is a typical part of most visits and should be.
Yeah.
We're looking at, do we have to give every senior, equipment, which is expensive, or can we courier it out or something? So I'm just wondering if you have any experience with that with organizations across the country.
Yeah, it's a great question, Adam. And you kind of hit on the answer. So you have a couple options. Option one is you're gonna have to bite the bullet there on the cost and provide the hardware for some of that. Look, depending on what you need for vital signs, I mean, obviously you're looking for blood pressure for sure. You're probably looking for weight, I would imagine, with some of those individuals, pulse ox perhaps. That there's opportunities there to use some of the equipment that may already be in the house. So like for weight, right, we see Bluetooth enabled scales are not that expensive. Frankly, you can get individuals to be okay about taking their own weight and kind of delivering that. From a blood pressure perspective, there's Bluetooth enabled blood pressure cuffs. They're not cheap, but they're not crazy expensive. So I would offer that you probably want to build out the kind of equipment side of things in an incremental way to sort of shift the cost out over time. That is one way to do it. Prioritize those who are more poorly controlled, right, to where you're going to be spending more time with. That might be one way to do it. Or you hit on the other one, which is you courier it out, and you're going to actually take almost a modified hospital at home approach. And there's a certain amount of at home care that you're baking into this as well, right? So it's a combination of, remote patient monitoring plus the actual in-person visit being brought out to the home. And you can determine how frequently do they need to go to the home, how frequently can we just have this be a completely virtual interaction. There's ways to work around it. Look, there's not a perfect answer yet. The good news I can tell you is two things. One, there are kits, things like, what's it called? Title Care, that's the name of it, which kind of offers a more comprehensive kit for a relatively inexpensive price. I think they're $200 or $300 or so for the kit, and it gives you a bunch of those types of Bluetooth enabled peripherals. The other approach, besides the kit part of it, that's a little bit more futuristic, but to be honest, it's coming a lot faster than you might think, is the Internet of Things that I mentioned earlier. So this idea of embedding sensors into different devices. So smart devices, we see them every day. Well, those smart devices can actually be used to take a lot more passive readings of individuals' behavior, which is actually cleaner data in the end, and have that be translated out into actionable insights. Short run, not great answers for you. There's some opportunities there. They're, less than ideal, but they can be made to work. In the midterm, there's some other opportunities that are still being evolved and refined. And then future focus here, there's a lot of tech that's coming really, really fast that I think is going to solve those issues and make that a much easier lift for you. So wish I had a cleaner answer for you, but hopefully that helps a little bit.
Thanks, Chris. Thank you.
Chris, this is Ann. Can I share to Adam?
Please.
Okay, Chris, we have some digital health solutions, a digital health platform. It's called like App Nucleus, where it actually utilizes exactly what Chris was sharing. It takes all of the remote monitoring, whether blood pressure, cough, weight, thermometer temperatures, and actually inputs that data into like your smartphone, which then moves that data into an encrypted server, which then goes into a major EMR platform. So there are digital health platforms, and there's also digital, we have app scripts, which is, I apologize for that. We have what is called app scripts. So for diabetics and for different specific disease states, you can actually do these apps on the phone and then guide the patients. We're finding that it increases patient engagement and accountability. So as we move virtual care towards having the patients owning their own data and moving towards accountability and active engagement, AppScript and our App Nucleus is a digital health platform that implements these apps. Like Chris said, we want them easy. We want them simple so that especially the elderly population can apply and use them. But we also need to have education. So
couldn't agree more.
Those app scripts, you actually have the ability to educate patients as well.
Yeah, one thing that I want to add on to that, I like that a lot, and I appreciate that, Ann. I think the other thing I heard you say that I want to dovetail on real quick is you said the idea of patients managing their own data. Which, look, we all want to get to that level, and I think that's where a lot of this is headed. However, it's important to differentiate between the idea of managing data and actually deriving actionable insights out of that data. And the reality is that the vast majority of individuals, especially those who are older, are not equipped to actually be able to translate that data in an accurate way into actionable insights that change behavior. So that's the next level, is the discussion of, it's not just do we put data in front of individuals, right? Frankly, they don't know what a lot of it means or how to read it. It's how do we actually translate that into something that is an actionable insight that actually modifies behavior and is meaningful to the individual. So that's when we get into discussions around, what is meaningful behavior from a digital assistant perspective, right? So Alexa, Siri, Google Home, you can start to use those technologies to provide those proactive nudges that is actually based on individualized, specific, meaningful behavior that actually leads to improved outcomes and overall health. So I want to sort of add that on to the end there as you're thinking about kind of what does this mean moving forward.
Thank you. And another question has come in as well. Do you think CMS and other quality payment programs will accept home vitals for quality measures in the near future?
I always get a little uneasy reading the tea leaves with CMS too much. Because there's obviously, especially right now, a lot of politics being played with that. So I think that it's very likely if they are left and given to their own devices and given the authority to make those changes uninhibited, yes, I do think so. Overall, Sima Verma, many others have been very, very supportive and progressive around their thinking around the virtual health space. With that said, just like in virtual health, there is definitely influence there from Congress and others that may, lead to some of that being unfortunately inhibited. But we'll see. Time will tell. But in general, overall, yes, I think that's where we're headed.
Chris, can I share with that as well?
Of course you can.
I do believe it. I believe as ACOs expand, that the information from various sources need to be captured, and that quality data validates outcome. And yes, I do think that it will be captured to close gaps in care and to be able to measure outcomes with their ACO agreements.
Thank you, guys. And I do see Joseph Pye had commented something to the panelists, and so I went ahead and copied that into the chat. There's some further information in there for you guys as well. I don't see any more questions specifically that have come in for you, Chris. So I think at this point, I'm going to turn it back over to Dr. Chestnut.
All right, great. Thank you for that great presentation, all the interactive questions. I did see that Dr. Pye put on there about Medicaid covering some of these DME, and we've had success with providers prescribing that and getting that for our Medicaid beneficiaries. So that's also something to look at.
Absolutely. That's great.
Great. I would also like to call on Dr. Pye now to lead us in a roundtable discussion about the efforts that Vidant has done around virtual health, and to comment some about the program there, and to get some involvement of others into how they've utilized virtual health in their organizations. So,
Sure.
Dr. Pye.
Can you hear me okay?
Yes, you're good.
So thanks for inviting us to join. And this was really, I think, a fantastic discussion this afternoon. The comprehensiveness of the information shared removed a lot of what we have to add, because it's going to be a bunch of Me Too comments to a large extent. And I wanted to add too, I have Marcus Bost socially distanced in my room here, who is one of the administrative leads for our program. But we kept nodding our heads, Chris, as you were sharing some of your comments, and really appreciate those insights. For us in particular, I think one of the most impactful aspects of this whole kind of COVID world is the acceleration of virtual care. And we thought adoption was going to take in Eastern North Carolina probably another 5 to 10 years to kind of really spin up as we were getting started. And with COVID, I think the demand just spiked tremendously. We went from little to no virtual care probably the beginning of the year to, at one point, as much as 40% of all of our visits were being delivered in that manner. And now we've settled down to roughly between 10 and 20%, very consistent with what you all have shared earlier today. And that appears to be something that has been sustained. We, from a COVID perspective, had two problems to solve. One was just the diagnosis and management of COVID to begin with. And with that, we spun up virtual care, developed a COVID nurse triage program and a virtual follow-up program, so that every patient that had a COVID-19 test had a care manager that was assigned to them, that connected with them immediately upon receipt of the result, and then followed them virtually to make sure that we connected with them, but did not necessarily drive face-to-face needs. And that worked very, very well. So we were able to keep in touch with these patients virtually, primarily by voice, but also by video, to make sure that they, had someone to hold their hand throughout this. But it also began to really kind of socialize that population to more kind of remote interaction, the telehealth concept in general. And then on the clinic side, we spun up our virtual care capability. I'm a primary care physician, so primary care to patients. We connected our specialists to patients. We connected our hospital-based specialists to patients. And then we also expanded our tele-ICU programs to 8 hospitals in our system, hospital to hospital consultation, and really had the leveraging on all fronts to be able to do that. And now that our COVID comfort has increased and our volumes are returning, we're finding that everybody has really enjoyed the convenience of that, mechanism of care. And so even though we're bringing more patients into our hospitals and our clinics, we're keeping up with the virtual care platforms to a pretty high extent, and also getting more interest in how to expand. So it's really been a spectacular process for us to see that evolution. And I'm sure others are kind of having the same experience.
And I put this in the chat, but if there are any attendees that would like to speak up at this time, please raise your hand. You should have a control across your bottom to raise your hand, and I can promote you to be allowed to talk. So if you do want to join in on the conversation, we would be happy to have you. Just don't want all 43 of you trying to talk at the same time. So we're going to try to control that.
I think it's really exciting, some of the unique ways that we've tried to use televisits as well. As you saw on the initial slide, we do a lot in endocrinology around diabetes. Part of that is also our health education program. And so we're looking at creating communities and group visits using Zoom technology with our patients, because we had a very successful health education that focused on group visits for diabetes patients. So that's something that we have created a small pilot idea, and hopefully we'll get that in concept soon, of communities that can communicate this way in group visits. So we think that's going to be a unique way to apply this technology as well.
We had a surprising uptake in our surgical populations too, pre-surgical. We extend that to the Outer Banks. So your colonoscopist, might be a 1 to 2 hour drive away, and to be able to have that initial consultation and then come on up, as well as some of the post-op follow-ups have worked really well for us. And pushing into the primary care, chronic care, those visits, I think we mentioned earlier about really socializing to the right diagnoses, not necessarily the low acuity, but some of the higher acuity, and really helping our folks to understand where, if you don't intend to have a physical exam, that you can leverage this technology to really increase the access. Chris, you had mentioned about the low acuity, the inappropriate use versus the kind of untapped potential, and really maybe a barrier that our traditional system had put in place. And I think we're really feeling that by making the care easier to attain, that we're getting access to more demand earlier in the continuum. And we're hoping that that means for us, we're not getting patients so late in the discussion, and that we can keep them out of the hospital, keep them out of the ED. And I'm crossing my fingers that that bears fruit and keeps that access, portal open.
And in the primary care space, we would ideally like to be able to, with our on-call providers, being able to provide this type of access. We've done a little bit of that, but haven't consistently been able to provide those services, but definitely an area that we're looking to expand as well, talking about ER, avoidance, in the middle of the night or late in the evening, to be able to pop on and see the provider on call. And I'd love it if other groups have had good experiences with that, because that's another area that we'd really like to develop.
I think it's interesting you bring up primary care, right? Because one of the things that I think is an interesting concept I'm seeing a lot of organizations pursuing, but it's challenging, is thinking through the implications. You stand up a low acuity on-demand service, great. And you kind of have to do that, because if you don't, we know that patients are gravitating in that direction anyway. And so it's either you stand it up and shift the volumes in that direction, or they're just going to leave the system overall. But there's some implications there, right? You're pulling all the low acuity visit volume, or at least a lot of it, out of your primary care offices. You're pulling it out of your urgent care. You're pulling it out of the ED. From a primary care perspective, if I'm a primary care physician, you just took the bumpers out of my day, right? And so my day just got a lot harder, because the vast majority of patients I'm seeing now are going to be more chronic, more complex. So how do you think through accommodating for that? In terms of scheduling, in terms of additional support, in terms of, incorporating virtual into that capability as well. There's some interesting care redesign discussions there that I think need to be considered as we continue to stand up and scale these types of capabilities.
Any questions, Danielle, or other comments from attendees?
I have not seen any other questions come in. No, and I don't see any hands raised. You guys do not have to come on camera if you don't want to. If you do just want to jump into the conversation, again, just raise your hand and I'll be happy to pull you up.
I'll add one innovation that we're looking at now. Connecting early with care management for the COVID folks really was fantastic, and we've managed more than 10,000 patients over that platform, so the demand was really high. We found that certain demographics of our population were testing more willing to engage in virtual care than to come into the office, and we're looking at that more, but certain disadvantaged community members felt like this was an easier way for them to access that care, and they felt more comfortable. So we are looking at that. Of our 24-hour virtual care service that we've loaded on that low acuity bit, again, Chris, we test them, ask them afterwards what their alternative to care might have been, and we're seeing about a 25% response rate that they would have been going to the ED or an urgent care, which would have been a much more costly delivery mechanism for that. Based on that response, we're now working with our emergency departments to see if we can leverage this platform to do follow-up for our ED visits. So for those patients that are seen in the ED and the ED needs them to follow up and they might be unassigned, they might not have a primary care physician, for example, we do try to connect them, but can we set them up for a virtual follow-up? Because some of the ED recidivism has been an issue for us, and if we can try to identify that once they've hit the ED, let's get to them before they decide to come back and make sure that they're covered after that visit is something we're looking at now, and the volume for that we're anticipating is going to be quite high.
All right, I still don't see any hands raised or questions come in. And I know we've got about 4 minutes left on our agenda. So Dr. Chestnut, I will turn that back. Oh, wait, I lied. I do have another question. As soon as I say we're going to cut it. Okay, again from Adam, we're filing a virtual product complete with primary care, i.e. patients will choose a virtual PCP in some markets. We work in Medicare Advantage and health plans are catching on. Adam, I didn't see a specific question in that, so I'm going to let you speak.
Yeah, just more of a, hey everybody, just more of a comment, I think. The health plans will be driving some of this, and like alignment, we're actually in Nevada as our test market, we're setting up a virtual, so we're filing a health plan that has virtual care embedded in it, in that patients will choose a virtual PCP. The care through the virtual platform will be free. And so I'm really interested to see how that's going to catch on, and kind of trying to lobby to bring that here to North Carolina too, maybe in 2022. But I think for all the folks here who work in primary care offices, I think the health plans are also getting into this space and creating benefits packages around virtual care. So just so so and that will drive some conversion to that as well.
Yeah, this is, well, you guys can hear me, this is Marcus Foss, Biden Health. Within that space, Adam, yeah, I'm seeing other vendors, specifically familiar with the MD Lives platform, and they're standing up the virtual primary care practice, where they're actually themselves moving into the PCP space, where you'll be able to go to them and use your primary care doctor. Will be one of their providers. So it'll be virtual from, all the way through. Obviously, they're going to send you off someplace with a partner to get labs or whatever. But they're actually, it's neither an insurance carrier nor a traditional healthcare provider moving into that space of primary care.
Great. Well, I think this has been a fantastic first virtual population health meeting. So thank you all for attending, and then for all the panelists with the great information that you've provided. It certainly renewed my energy and to look into how we can utilize telehealth to go forward and make progress to continue to provide patient care. So thank you. I don't know, Danielle, if we have a save the date for when our next meeting is.
Stay tuned. We will be sending out some follow-up information. We'll include some contact information for our presenters today and some further resources, as well as some links so that you guys can access everything. And we will be sure to include some dates to stay tuned for down the road. And again, thank you all of our presenters today with the wonderful information, and thank you as well, Dr. Chestnut, for hosting for us today. So thank you all, and we will be in touch.
Sounds great. Thank you.
Thank
Bye.
you. It's an honor to serve.
Thanks.
Be well, be happy, be healthy.